Hi, my name is Michaeline Holdmarch, and I am a healthcare transformation expert and deals with compliance and governance and safety, all the good things around healthcare. And I'm joined today by no other than Professor Rotimi Jaiyesimi. And what we're going to talk about is sepsis. We are actually planning a sepsis symposium in St. Lucia on the 5th. So you got to be there. But let me introduce you to the dynamic, professional, and the expert in this field, Professor Rotimi Jaiyesimi. Welcome, Professor Jaiyesimi.
Yeah, thank you, Michaeline. It's a pleasure to be with you this afternoon. I'm looking forward to an exciting, educative meeting. Thank you.
Great stuff. Sepsis is something that I thank you very much so on behalf of the diaspora, of our beautiful skin tone. I thank you for actually helping with the recognition that when we are ill, to please, our lips don't go blue. We don't have the clinical, symptoms that you see on our Caucasian brothers and sisters. We present differently. We don't go, red and rashy, and we don't have all of that because of our beautiful tone. And so, unlike our brothers and sisters of the Caucasian and the more lighter tones, it's so much easier for you to identify and rule out what potentially could be going wrong. So, can you just bring us up clinically in regards to what is really sepsis? I think that is the big word, isn't it? Sepsis. What is it really?
Yeah, thank you once again, and thank you to our participants, those looking and observing what we are talking about today. I think first and foremost is to give a brief introduction about myself. I'm the Associate Medical Director for Patient Safety in one of the largest NHS hospitals in the United Kingdom. And I lead on the sepsis group, and an expert on sepsis, having been doing this for the last almost 20 years. So I speak from that point of view. Now, globally, people are just becoming to get to know what sepsis is. It's always been there. We've called it toxemia, we've called it infection, but we now know that it's a global problem, a burden on the world, with over 160 million people having sepsis annually. So you said, what is sepsis? Sepsis starts usually almost entirely from an infection. It could be in the lungs, it could be a bladder water infection, it could be an injury to the arm, or it could be after surgery where the patient develops an infection. And if not well managed, the body goes into overdrive in trying to combat the infection. And that's where you now get the symptoms of sepsis. The patient has got the temperature, they feel drowsy, they feel disoriented, they feel unwell. And speed is of the essence when you do have sepsis. So it starts with an infection and then it
So
has
before
its
you
own.
before you go on from one person in healthcare to the other, we talk about that golden hour. And I know in your book you are capturing that golden hour. Could
Yes.
you tell us before you go on about that golden hour? Because many healthcare professionals, including myself, someone come in, they're coughing, they have a high temperature. Sometimes you need to actually differentiate, isn't it? Whether this is just a flu or if this is going towards a deteriorating patient status. So tell us about that because you are gonna have your book, Golden Hour. Can you tell us about that? Because people around the world is keen to know about this. And as a matter of fact, our global goodwill ambassador for the Caribbean Global Institute, Dr. Cami Holder, who is from Barbados, said today to me about his friends and a couple of people have died. Even today, someone died from sepsis, and it's really troubling him as a goodwill ambassador, Mr. Kami Holder from Barbados. So I hope you will be able to pick up on this. I'm going to ask that question again. What is that golden hour? Tell us about it.
Yeah, before I mention that golden hour, I haven't mentioned what's going on in Barbados. On behalf of BIM Health Collaborative, the Caribbean Global Institute, would like to relay our sympathy to
Very
the
much
Prime
so.
Minister of Barbados, whose
Hmm.
brother died of sepsis last year. So
Wow.
our sympathy and condolences are to the family. Now, the
And to
golden hour,
all the other families who you just been told this word, sepsis kill your brother, your relative, your friends, please note MHM Health Consultancy, BAME Health Collaborative, and the Caribbean Global Institute, we are trying to do something about this by informing you. And so this is really important. I want you to take this webinar, this discussion, and share it. Share it. And when you go to the hospital, you ask, is this sepsis? Do you
that's
think
it,
this is
absolutely.
sepsis? So,
Yeah,
so go ahead. Tell us about that golden hour.
right. That golden hour really starts from when there's a trigger. There's a suspicion. You've just said, could this be sepsis?
Mm,
And until proven otherwise, we've got to assume that
mm-hmm,
it is sepsis and the clock starts ticking.
mm-hmm,
And usually there are three things we have to do, three things that have to be done. And
mm-hmm,
that constitutes the sepsis 6 bundle that
mm-hmm,
has to be completed more so in people where there's medium to severe illness. And
mm-hmm,
what do we do within that golden hour? Awareness is important. And as soon as they come into hospital and you say, this could be sepsis, you start by taking bloods
mm-hmm,
for investigation. Specifically, you want to know whether the inflammatory markers are high. You want to know what the blood gases are like. You also then take bloods for culture to find out what organisms are growing within the body so that you'll know what antibiotics to give essentially. So those are important in taking. After you've taken your blood, within that golden hour, you administer oxygen, you administer fluids, and you administer antibiotics. Very, very important that these are completed within 60 minutes in patients who we think this could be moderate to severe. In patients where we think it might not be, we could extend that to about 3 hours, completing all those 6 tasks within 3 hours.
yeah. So I'm antimicrobial.
That's
That's it.
correct.
And I am an ambassador for antimicrobial use and the whole context. So we push forward this thing, this notion that we will sit back on using antibiotics. Do you know what I
Mm.
mean? So here you saying that, look, you've done all of this. Look at all the chemical pathology. You look at the blood works. You look at everything to do with that, and now definitely it's called for antibiotics. Some of us and some clinicians I know will be like, do I want to give antibiotics? And then after I give antibiotics, it turns out to be it
I can
wasn't
understand.
sepsis at all. And then I have to write some report. Well, if you are in the UK, you got to write some kind of report about why did I administer antibiotic? Why didn't I do ABC? But then we have the golden hour. So for clinicians who listen now, they're going, you see that thing about not using antibiotics too quickly,
Yeah.
and then I have to write a report. Tell us how they can navigate around this.
Well, I think where you're coming from is the antimicrobial stewardship
Yes.
to try and reduce antimicrobial resistance, which is another problem. So it's catch 22 situation. Do you give antibiotics? Are you thinking about antibiotic resistance? But the thing about sepsis is that mortality is very high, and every hour lost increases the mortality. So usually what happens, like I said, you take bloods for the blood culture, but we don't know what organisms are growing. But you give antibiotics within that hour. Then comes the senior review. Uh, and before I talk about the senior review, technology has made it possible that we don't have to wait for 3 days, 5 days before we get culture results to know what organisms are growing. You have a rapid turnover. So usually if you've started antibiotics, if you eventually, maybe within a day or two, think that no, this is not sepsis, you can step down antibiotics and look for what else could be the cause of the patient's problem. So
And
that's the way we
exactly
get
that. Step
around
down. You can step down, fellow clinicians and healthcare professionals. It's okay to
definitely.
step down. Look, most people out there who are, presenting at whether an urgent care, emergency department, or even as an inpatient, there is a bias. There's a bias in regards to Black and ethnic people in regards to presentation with the type of infection, whether they think you have got HIV, you've got some maybe a tropical illness, you have so many other biases that come in. And by the time the identification that it is actually sepsis is much too late because we're talking about organ failure now. Yeah.
Yeah,
So we have to do something more. And I will come in about the governance and the policy and looking at how we navigate that. But before we go about that, I think the data speaks for itself. And you are a data guru. I've known you for many, many years. And I
yeah,
remember when we did one of the biggest public health issue to ever face an acute trust. We
that's correct.
managed that smoothly, and the data for that should actually transform, inform, and reform how we actually use data for in a lab setting. Yeah. So data and the metrics behind that, the trajectory about where it's going, what we're doing with it, should actually form the basis to actually preempt the care that we are going to deliver in regards to policies, SOPs, deteriorating patient, first glance, identifying the key aspects that you're going to look for, the triggers. So can you tell us the triggers? So my good friend in Uganda, because I serve on the UAPHGO and the GPHU as a professor for the Global Health Public Health University and all the other places around the world. Please, can you tell us some fundamental triggers?
Well, I think my starting point, having mentioned data is the new currency. So we need to capture what we do within the health system, within the health, or within the hospital. Now, talking about the trigger, like I said, awareness is important. And I'm happy you mentioned the melatonin that Black people do have. Um, I mean, we don't manifest mottled skin appearance. So if we're looking for mottled skin appearance in a Black population, then you're going to miss a lot of people who have sepsis. So I put that aside because we as Black people have to define what we are going to use, what parameters we are going to use in trying to get a diagnosis of sepsis. Now, like I said, having collected data, for example, you want to know what, I'll give you an example of lactate. Lactate is very important. If it's over 2, it's signifying that there is some infection going. So it buttresses the fact that this could be sepsis. Another chemical that is data driven is procalcitonin,
Mhm.
not readily available globally, but again, it's an index that one can use to determine whether this is sepsis. Now, managing sepsis draws resources, and using the data, if you have a good sepsis framework where you can show that having instituted the sepsis 6 bundle, you've been able to reduce the length of stay in hospital, maybe by from 10 days to 6. You've been able to reduce mortality and even morbidity
Hmm.
because just like long COVID, people have issues after they've survived from
Yeah,
sepsis.
and we're gonna come
So,
to that aftercare in a moment. But
yeah, so all those data that we have, again, appropriate use of antibiotics, just reduction. I think the key thing is ensuring that people do not die from a condition that is preventable, that is treatable. You've got sepsis. If you make a correct diagnosis, institute the appropriate management, then the outcome tends to be very good. So that is where using data comes into the picture. Thank you.
yeah, but I keep saying that a sepsis dashboard,
Yeah,
yeah, would actually be a very good and robust framework for any hospital clinics to introduce. You could expand it to other infections as well, but having that dashboard whereby you can see the number of patients who came in for this month, how many had sepsis, how many deteriorated rapidly in that golden hour,
yeah,
how many passed, unfortunately, how many were kept in hospital, treated and recovered and went home. And therefore, from that, you will be able to identify what did you do differently every time? What was the learning? What you need to improve on? What clinical guidance was followed? Who were the people were on that day? Because we don't believe in blaming people, but what processes did they introduce? How quick? What made them decide that this person cannot wait any longer in the waiting area
yeah,
and needs to be pushed forward to be seen quickly by an expert, competent clinician? You see my words? Someone
yeah.
who has the experience in identifying all of this. But there is something we haven't talked about.
Before we go on to
Cold,
that,
cold infections,
I
cold
think
temperature.
yeah,
No, you got to talk about that because you see, most people think that when someone presents to A&E or any of the emergency settings and the temperature is not above 38.5, 38 something, well, they have that rush. But someone whose temperature is not that and is below 35 coming down, oh, they just call, I just need to give you a blanket. No, Professor Rotimi, we got to educate our people about cold sepsis.
yes, I see where you're coming from, and it is absolutely correct. You don't have to have a temperature or fever to be told you've got sepsis, because you can have very low temperatures even when you have an infection. Like you said, cold sepsis or cold infection, or maybe even cold abscesses. And let's not forget, in certain parts of the world, where we talk about antimicrobial misuse, people start taking antibiotics. They don't have enough money to take the full course of antibiotics. And because they've started on antibiotics, it contains the infection up to a certain extent. And then they could have cold sepsis or cold infection. And we've also got to be mindful of our elderly citizens, because they don't always have a temperature. At times, it's the reverse that they have when they do have sepsis. The
Mhm.
temperature doesn't have to be roaring 38, 39, 40
Exactly.
degrees. In
Hmm.
some patients, it is very low. That is hypothermia, uh, is an issue. But there are other factors, like we've said. We should take the patient as a whole human being. If the family come in and say, our dad or our brother or sister is not the same as he or she was yesterday or over the last few weeks, we as clinicians, healthcare practitioners, must listen to them and take action. We must listen to the history we are being given. And before I go on, you mentioned the dashboard. Electronic health records are now coming in place. We haven't mentioned the new score, which is electronic early warning score,
Mhm.
national early warning scores, that takes into account the temperature, the blood pressure, the pulse, the oxygen levels of the patient, and you compute that into a calculation. And if you have a dashboard and a trigger, if it's connected with technology now, if it's 5 and over, it triggers, it goes maybe to the outreach team, an emergency team, and they know that there's a patient somewhere whose national early warning score is over 5 or over 7 or deteriorating, and then they can go to that patient. That's the beauty of having an electronic health records as well as a real-time dashboard. And I do hope people will invest in that. It's the way forward. Thank you.
Thank you. We don't have much time here, so I just want to talk about board to floor. Board to floor is so important in regards to the management of any major serious or any serious incident, and how often we talk about data, how often that's happening in your organization, in your healthcare organization. And I always say one death is too many. Yeah.
Yeah.
One death is too many. And two deaths, you should be starting to think. And three, four, five, it's becoming a habit. And why? In this time of modern technology where we do so much remote conferences, healthcare conferences, and there's lots of shared learning, I want to talk about the Caribbean Global Institute position here. As the sole founder of Caribbean Global Institute and also the founder of the BAME Health Collaborative, which is a charity, and Professor Rotimi is a chair there. One of the things is that we are driving forward is that shared learning. So we are also having our virtual referral center so that no matter where you are in the world, you could actually say, hey, I've come across a problem, I'm being diagnosed, but you know what? I want a second opinion outside of my location, outside of my region. You could
Yeah.
actually contact us, and we will actually, for a small fee, we will actually refer you to clinical specialists and experts in that particular illness or diagnosis or whatever you will prognose, whatever is your prognosis. But Professor Rotimi, Caribbean Global Institute is pivotal, and with BAME Health Collaborative and the MHM Health Council, bringing that together so that we can actually help to inform our
Mm.
colleagues and also the general public about the things that affect us. We have Men's Health coming up, and we would be in St. Lucia. Thank you to the St. Lucian government. We will be there on the 5th of June running a health care symposium specifically on men's health, sepsis, and cancer, because we recognize that something has to be done. We need to do more. We need to do some fireside chat. We need to do
Yeah.
some round tables. We need to pull out some sticky tapes and some lovely charts and work through it and just reflect and be innovative in what we're doing, how we're doing, and why we're doing it, and why the patient outcome is not what we expect.
Mm.
So I know there's a lot of clinical guidelines, the sepsis bundle. There's so much guidelines, and it can be confusing actually,
Yeah.
because policy to policy changes. You pull out a policy from Ghana, you pull a policy from here, you
Yeah.
put it all together. It's absolutely the standardization globally, it hasn't reached there yet. And my concern is that it doesn't actually specify that my people, my people are dying more than anybody else because our illness, our recognition first, we got sick. We take a long time to say, I really need to go to that. I'm going Caribbean now, right? You really need to go to the doctor. I see what I can drink up, girl. And it's the same thing like Africa. I'm always in Africa. It's like we always think we wanna find our own medical doctor in here and what our great grandparents used to boil and think. So we need to change that because sepsis kills. You don't wake up
Y-
from it if you present late. So we have a problem. People,
Yeah,
we have a
this
problem.
is where
We
awareness
present late
awareness
all the
is
time.
important. Yeah.
Go ahead, Professor Rotimi. Help me with this.
Yeah, I said this is where awareness, public awareness, is important. Again, we are faith-based people. I think the two can come together. So if somebody is ill, yeah, please get attention, seek medical advice. I'm happy you also mentioned the virtual consultation. What you have said is akin to what happens in the United Kingdom called Martha's Rule.
Hmm.
Martha was a teenager who died from sepsis. And following that and investigations, the UK government brought in a rule that empowers families to seek a second opinion from healthcare professionals. And that's where our own virtual service at the Caribbean Global Institute, the BAME Health Collaborative, MHM Consultancy come into the picture. Now, you also spoke about the different bundles of care or framework. The good thing is that the world as a small global village is coming closer and closer together. As late as yesterday came out an agreement by the Surviving Sepsis campaign, where they have issued a framework that is not too dissimilar from what we use in the United Kingdom. So, talking about Africa, talking about the Caribbean islands, talking globally, I think we're all coming to a consensus about how to tackle this global burden that kills a lot of people. We talk a lot about cancer, we talk a lot about cancer, but it will surprise people that one third of the deaths in the world is due to sepsis. So
Yeah.
we have to address this scourge in society. Thank you.
Thank you. I just want you to go back a little bit about, and I know it's going to be a little bit, you know, contentious in some aspect, but in medical school and in nursing schools and ACP's training, are we missing something here?
I think so. I mean, that's historical, but with ongoing events globally, medical students, nursing students, midwifery students, people who have face-to-face contact with patients are now being taught about sepsis. What the key thing is, what is sepsis? Could this be sepsis? We have to have that heightened awareness to be able to tackle the disease. And I think the message needs to be clear, not just in the United Kingdom, just it's a global problem. And I will also support, and which is what we're trying to achieve by having webinars such as this, is to create that awareness, not just in the public, but amongst professionals as well, because we do miss it and we have to learn from cases that have occurred in the past.
Thank you so much. I just want to ask you to tell us about your book because I
Mhm.
think, you know, it's all well and good for us to go on nice and pull out all of this data that is coming from everywhere. But I think it's so refreshing because I've been doing the searches and trying to find just a little book that will tell us. We could even have it pocket size. I think you're doing pocket size so doctors could have it in their little pockets, and also the master copy. Can you tell us a little bit about that book because it's soon to be released?
Yes, it's coming very soon. Thank you for giving me the opportunity to talk about it because sepsis is one of the things I am very passionate about. And the book is Decoding Sepsis, using data to decode sepsis,
Do
to
you have a
drive in.
picture of it so that you can show us?
Oh, I haven't at the moment. I haven't got one.
I think I do. I will
I
bring it
sent it
up.
to you. Oh,
Yep.
yes, that's
Ah,
it.
there it is. I will move aside
Y-
so people can see this powerful book.
Yes, the silent epidemic, decoding sepsis with data. That is the book that's going to. I'm drawing on practical examples. I'm drawing on the experience over the years. And like I said, it's a condition I'm passionate about. It's the silent epidemic. We shouldn't be losing people to sepsis. So watch this space. As soon as it's launched, I think we will let you know.
Thank you so much. Well,
Thank
you,
you.
for me, it's really doing the clinical governance dividend. And so I will briefly talk about that. My name is Michael Marge. I have an honorary doctorate in clinical science, but my background is healthcare. You can find me on any of the social platforms from Google, all of that. But what I want to say is that clinical governance play a very important role. It's one of the key pillars in ensuring that patient outcomes would be better. And that's the reason why I decided to write this book, because it's forgotten. We get captured into operations, we get captured into um, all the other aspect of a healthcare business. Oh,
Financials.
I didn't even want to go finance yet because I was coming when a patient start to sue, then you wake up. And when there is external stakeholders or government interests, then everyone talk about the assurance aspect. But Clinical Assurance Dividend is my book, and I hope that you will have a read, and also the 5 P's Master series that I've just released on policy, people, participation, process, and actually the promotion of health. It's really important that you look at your current system. What assurance are you giving not only to your colleagues, but to the patient voice? What are you doing? What are you following? Are you following your own subjective views? Are you following an agreed plan for sepsis? Do you have an agreed plan? Do you know how to escalate? Or are you one of those who become so cocky that you would escalate it at all? You would ask a colleague for an opinion. We have to break away from that, Professor Rotimi. So,
Most
and about
definitely.
creating forums, clinical governance assurance forums, whereby clinicians will come and present their cases, and we can dig deep into why without that blame on that clinician, giving them the
Yeah.
confidence for us to look at it and in a real, looking at the data, looking at the clinical history, looking at the patient history, and tearing it apart so that we can find areas for learning and improvement. And before we end this beautiful, wonderful series, I just gonna throw something into your patch right now. What about that sepsis patient who has been taken to intensive care? And the family, all they know, it's an infection. I want to say to you, before they even get to that, what would be the message from you, an expert, to someone who is at home right now and they're feeling unwell? They may have cold sepsis, or they may just be feeling very unwell. They've had a lung infection before and they were given some antibiotics, but they still feel very unwell. What is the message are you going to give to them today? And what is the message you want them to say when they get to that emergency center?
Thank you for that question. Very nice one. It's the access to healthcare. The services are there, but at times, like we discussed earlier on, people want to observe things at home. At times people say, oh no, I don't want to disturb my doctor. I was there last week and stuff like that. No, early access of healthcare services is important. So if somebody is unwell, please access medical services. Like I said, faith as well as science go hand in hand. While we undertake the faith aspect of praying in whatever our faith is, we should seek medical and nursing attention as well. Very, very important. When we do that, and when you get to hospital, because doctors don't know all of these things, nurses don't know all of these things. The nurse you meet at the triage at times doesn't even know how unwell you are. By just prompting healthcare professionals, could this be sepsis? Triggers that thought process of, oh, yeah, let's explore that. And in doing so, if it is sepsis, then we nip it in the bud and institute the appropriate management.
So, Professor Rotimi, I would like to thank you very much
Thank you for having me. It's
for
been a
joining us
pleasure.
on this global conference. Are you excited about St. Lucia and us having this big
Mm, Most
fireside healthcare
most
where we're calling
definitely
for posters very soon,
the 5th
presentation?
of June, definitely. Yeah, I'm looking forward to that. Yeah, I am looking forward to that. It gives us that opportunity again to let people know that we are now coming together globally to agree on what is sepsis, what's the best management, and the importance of taking the public along with us. We have to get the public engagement through public health awareness and public health education. And we have to learn as well as clinicians. So thank you for this wonderful opportunity. It's been a pleasure being on the program with you.
Thank you so much. Last words that really get some of the clinicians keen to join us in St. Lucia. What would be your take on that?
My take on St. Lucia. I mean, I've never been to St. Lucia, but I have no doubt that it's a beautiful island. I can't wait to see the blue turquoise sea and perhaps to talk into the local food. Barbados, that was where I first had my sea bars. And since then, anytime I see sea bars, I want it. But it's never has been as tasty as the one I had in Barbados. So
Oh
looking forward.
boy! Well, that's my grandfather land. So okay,
Well, I
don't
mean,
say anything.
I've said it as it is. Let's see what St. Lucia has to offer us.
Okay, great. I would like to thank our ambassador, Diane Felician, for the work that she's doing in St. Lucia. But more importantly, I need to thank Mr. Julian Ajoa, who is one of our fellows for the Caribbean Global Institute, and he also received
Yeah,
award as well. And I just want to say thank you for all that you all are doing, driving this forward, and all the ministers who reach out and had a conversation with us in regards to the Caribbean Global Youth Awards. We are really excited by that and to actually develop some healthcare champions. Probably could create some champions in sepsis as well. That would be a great thing to do. So, on behalf of the Caribbean Global Institute, BAME Health Collaborative Charity, MHM Health Consultancy, I'm Michaeline Holder-March, and I'm saying thank you so much for joining us today. Thank you all for being here today. And thank you so much, Professor Rotimi, a dear friend and trusted brother. Thank you.
it's a pleasure and thank you.
Thank you.